consultant anesthetist working at Army Hospital, Colombo. Over to you, Nimangi.
Good morning, everyone. Now we will move on to discuss how you could support the breathing of the patient under your care. So what exactly is your role in supporting this patient's breathing? You must monitor and recognize a patient who is deteriorating in his respiratory functions. You must also provide oxygen therapy and facilitate non-invasive ventilation, assist in intubation, and facilitate invasive ventilation as well. Provide ventilator-associated pneumonia prevention care and oral care, and facilitate physiotherapy and suctioning of airways. Also the care of IC tubes. So how would you recognize a patient who is having respiratory distress? On the outset, you might recognize that the patient is cyanosed. He might be restless or drowsy. He might be sweating, has a headache. He also has facial flushing, tremors, and he might be leaning forward, unable to breathe. Specifically, when you examine the respiratory system, you might see that there is dropping saturation, an increased respiratory rate, reduced chest movements, stridor or wheezing. He might be using his accessory muscles of respiration, and he might not be able to complete full sentences. And you might notice an increased need for supplemental oxygen as well. So once you do an ABG, you might see that there's hypoxemia or carbon dioxide retention. So in these kind of patients, you need to start oxygen therapy. How would you start oxygen therapy in such patients? So oxygen is given via an oxygen delivery system. It's something that is used to administer, regulate, and supplement oxygen to these patients. And the device is decided upon depending on the degree of hypoxemia, the requirement for precision of delivery, patient comfort, and cost. And you must remember the priority is to maintain oxygenation, as you need to maintain a fine balance between the supply and the demand of this patient in order to prevent ischemia or further ischemia in your case. And you must target a saturation of 94% and also an oxygen PO2 of 80 millimeters mercury. So what are the devices that you can use? The devices can be divided into low flow or high flow systems. Low flow systems do not provide a constant oxygen percentage, while the high flow systems do. The types of low flow devices available are the nasal cannulae, the simple face mask, the non-rebreather face mask, and the tracheostomy mask. This is something commonly encountered in your practice, I am sure. The nasal cannulae consists of two soft prongs attached to an oxygen supply, and it can give up to about 40% of oxygen when you give it at 4 liters per minute. But anything above that can cause discomfort and drying of the nasal mucosa. So advantages are that it's lightweight and comfortable, and the patient can eat and speak with it. Humidification is not a requirement, and the cost is low. But there are some disadvantages, such as irritation of the mucosa. It can't be used when there's nasal congestion, and also the oxygen percentage delivered to the patient can vary with the patient's respiratory efforts. And high flow rates can be uncomfortable for the patient. This is another device used very commonly. It's a simple face mask. You can see that it has a reservoir of about 250 milliliters around this area, and the oxygen delivered can be highly unpredictable, again depending on the patient's respiratory effort. Also, since the carbon dioxide which is exhaled from the patient can be accumulated in this area here, it can cause carbon dioxide rebreathing. But at about 4 liters per minute, it can provide an oxygen percentage of about 40% in a patient with a normal respiratory pattern. So it's less expensive and can be used in mouth breathers as well. And the disadvantages are that it can be uncomfortable and requires a tight seal, and it does not deliver high oxygen concentrations. Also, the concentration you deliver can depend on the patient's breathing efforts. It can also interfere with eating and drinking and communication. And like I said, there is a chance of carbon dioxide rebreathing. So, another low flow device is the non-rebreathing mask, which is commonly used nowadays. It has a mask connected to a bag with a one-way valve in between, and this bag acts as an oxygen reservoir. When the patient is not breathing or inhaling, the oxygen that comes through this oxygen supply device will accumulate in this bag, thereby forming a reservoir of oxygen. And you can give up to about 95% of oxygen at 15 liters of oxygen flows. The advantages are you can give a very high oxygen concentration without intubation, and it's suitable for spontaneously breathing patients who are in severe hypoxia. But it can be expensive and it can be uncomfortable for the patient, and interferes with the eating and the drinking, and it's not suitable for long-term use because if the patient is severely hypoxemic and severely compromised, the patient can easily get exhausted because it does not support the breathing efforts of the patient. And also the malfunction, any malfunction will cause a carbon dioxide buildup and resulting in suffocation. So patients who have variable respiratory efforts, the high flow system is your best choice. So the types that are available and commonly used are the Venturi, high flow nasal oxygen, CPAP and the BiPAP machines, and the ventilators. So the Venturi mask, I'm sure you have all seen these, is a plastic body connected to the mask, and they are color coded, as you can see, and they provide various concentrations of oxygen at various rates of oxygen flow. If you take the green Venturi, for example, it provides 60% of oxygen when you give 15 liters of flow through the device. And then there are calibrated ones which are adjustable, which do the same, serve the same purpose. So oxygen can be given at 24 to 60% through these devices. The high flow nasal prong is another device that is commonly used, and it delivers heated and humidified oxygen at very high rates, such as 70 to 80 liters nowadays. And this also offers a positive nasopharyngeal pressure at the nose, which transmits into the upper airway and offers a PEEP of about 5 to 10 millimeters of mercury, and the oxygen percentage remains relatively constant right throughout. The flow is warmed and humidified and therefore offers little discomfort to the patient. The advantages in this is that it's easy to operate, patient is comfortable, and the compliance of this patient is better, and feeding is not compromised. It prevents invasive ventilation and less damage to the nasal mucosa, and can prevent severe hypoxia. But it can prove to be costly because you use very high flows of oxygen. That is, I think, one of the main disadvantages of using that device. The non-invasive ventilation devices, again, commonly used even in the ward setup nowadays. It consists of this instrument which provides the ventilation and a tubing and the interface which connects the machine to the patient. There are mainly two types of non-invasive ventilation. One is the continuous positive airway pressure, the non-invasive positive pressure ventilation. So the continuous positive airway pressures, that method will provide the patient with a continuous pressure right throughout the respiratory cycle. So it prevents atelectasis and improves the functional residual capacity, it prevents airway obstruction, and also has an effect to reduce the left ventricular outflow, which might be beneficial in our patients. The non-invasive positive pressure ventilation will offer a positive pressure during inspiration, and it can reduce the work of breathing and improve the tidal volumes of the patient. So before you initiate, you must be competent in handling these instruments and giving these patients advice. You have to ensure that the patient is compliant above all. And you must know how to choose the exact mask or the interface that suits your patient. And ask the patient to breathe through the mask before you connect the patient to the machine, because then the patient is less anxious and much more comfortable with the machine, and it will help you to reduce anxiety and any dysynchrony between the machine and the patient's breathing. These patients, though, should be monitored. The respiratory rate should be monitored, the level of consciousness, the chest wall movements, patient's comfort, the pulse oximetry should be documented, and blood gases, serial blood gases may be needed depending on the patient. And also you must make sure there are no leaks around the mask and there's no dysynchrony the patient and the machine. You may encounter a lot of problems while using this, you must learn how to pick them up and inform your superiors. So look out for facial erythema, claustrophobia, nasal congestion, aspiration, hypotension, development of pneumothorax, aerophagia. Patient may complain of headaches. Also, gas embolism is another complication that you should be aware of. There are various effects of using positive pressure ventilation. It can reduce the cardiac output and reduce blood pressure. So to facilitate or optimize your cardiac output, you might need to use fluids and inotropes. It can also reduce the renal blood flow. It can increase intracranial pressures and cause water and sodium retention. It can also have immunological and gastrointestinal effects. If you compare your non-invasive ventilation over invasive ventilation, the non-invasive ventilation leaves the upper airway intact and allows the patient to eat, drink and talk, and it's much more comfortable and convenient. Avoids the trauma of intubation and artificial airways, and reduces complications of intubation such as ventilator-associated pneumonias and ventilator-associated lung injuries. Also avoids the need for the patient to be sedated or paralyzed. So invasive positive pressure ventilation offers a controlled setup where oxygen can be delivered at high percentages, such as even 100%. And you need an artificial airway to connect the patient to the ventilator. And you can use various modes to improve the oxygenation. The gases can be humidified and it prevents the drying of the mucosa, and you can also suck out secretions easily in these patients. But the disadvantages are that it's invasive and requires intubation and sedation and sometimes even muscle relaxants, and there are numerous complications associated with mechanical ventilation. So what does this ventilator do? It assists in respiration and replaces the work generated by the ventilatory muscles and facilitates the movements of gas into the patient's lungs, but it does not support the expiration of the patient. This is what a ventilator would look like for those who have not dealt with ventilators. This is the patient with the endotracheal tube, and gases or air is provided through this tubing system. It is humidified before it reaches the patient, and whatever is exhaled goes through this into the filter here. And indications for intubation and ventilation could be to improve the lung mechanics of the patient, also improve the gas exchange or hypoxia in a patient. If the patient has a very high work of breathing, and if there's hemodynamic compromise, or in patients with raised intracranial pressures to control the carbon dioxide. Also, in your setup, you might encounter patients who are intubated and ventilated postoperatively till the patient is stable for extubation. There are various modes of ventilation used nowadays, and here are some of the commonest modes. The mandatory mode, where the machine takes over the whole respiration. Then the assisted modes, where the machine assists the patient's respiration in varying degrees. The supported modes, which uses pressure support and positive expiratory pressure and expiratory pressure. And the spontaneous modes, where there is a continuous positive airway pressure provided. So these are some of the common modes used, but there are numerous and various modes used nowadays. When you are dealing with the ventilator and a ventilated patient, it's important to learn how to prevent VAP, or ventilator-associated pneumonias, which is one of the commonest healthcare-associated infections in critical care units. It occurs about 48 to 72 hours after endotracheal intubation. And potential ways to prevent is reduce colonization of your GI tract, prevent aspiration, and limit the duration of ventilation. So in order to achieve those targets, the Institute of Healthcare and Improvement has set up a ventilated care bundle that should be practiced in all ICUs in these ventilated patients. So we need to maintain a head-up tilt of more than 30 degrees. We must use oral decontamination and provide good oral care for our patients. Provide daily sedation holds, so to decrease the duration of ventilation, keeping that in mind. Provide thromboprophylaxis and gastric ulcer prophylaxis. That comes to the end of the discussion.
Thank you, Nimange. It was a very comprehensive lecture on how to support breathing in a critically ill cardiac patient. Chamara, would you like to introduce our next speaker, please?
Yes, thank you very much. Yes, so the next speaker is Dr.